I'm going to present a brief update on macular degeneration. I have no financial disclosures. I have no affiliations with any of the drug companies or companies that market these treatments. The Retina Group of Florida conducts clinical trials for multiple drugs and treatments. The current trials are listed here. We also participate in National Eye Institute and National Institute of Health trials, including the DRCR AREDS and the CAT trial. So I'm going to just start from the very beginning with how the eye functions. So light comes into the eye in the front, goes through the cornea, pupil, and lens, and is focused by the lens onto the retina. Within the retina, there are two critical sections, the very center of the retina called the macula, and the rest of the retina, which is the peripheral retina. The macula is responsible for central vision, for fine acuity, things like reading, recognizing faces, seeing street signs. The peripheral retina is your side vision, and that's responsible for helping you navigate the world, see what's going on around you, see things on the periphery. There are two basic types of age-related macular degeneration, AMD. Dry, which consists primarily of drusen and atrophy, and wet, which results when there is neovascularization. Dry AMD is the result of age-related changes within the retina. Abnormal deposits form underneath the layer of the retina called the retinal pigment epithelium. These deposits, which are shown here in yellow, are called drusen. And as those deposits develop, small gradual changes in visual functioning, including distortion and blurriness, can occur. Eventually, overlying those areas of drusen, the retina can become thin or atrophic and not function as well as it used to. The other form of macular degeneration, which progresses from the dry, is called wet macular degeneration. The distinction between wet and dry macular degeneration is that in wet macular degeneration, abnormal blood vessels grow under the retina. These abnormal blood vessels, which you can see growing here, can bleed and or leak fluid. The end result of that bleeding or fluid is scarring under the retina, which can lead to severe visual loss. Although the majority of macular degeneration is dry, the majority of people who have visual loss from macular degeneration are those in whom the dry has converted to wet. There are several different avenues of attack to combat dry macular degeneration. It is a hereditary disorder, and new genetic testing has been developed which can indicate whether people are at risk, and if so, how high their risk is. For those already diagnosed with macular degeneration, that's somewhat irrelevant, but for their children or family members, the genetic testing can provide important information as to what their risk is. It also offers the opportunity in the future for genetic therapy, so that if we identify, as we have, the genes that cause macular degeneration, the next step, which is being actively pursued all over the world, is treatments specifically targeting those genes. It is clear that beyond genetic factors, there are other factors that cause people with similar genetic makeups, like twins, some to develop disease and some aren't. And many of these are thought to be oxidative damage. For that reason, as most of you know, it has been recommended for years to use antioxidant vitamins. The National Eye Institute completed a large trial called the AREDS trial, which identified and examined the benefit to the use of antioxidant vitamins. That trial continues in the form of AREDS2, looking at a slightly different compound, adding to the original formula of the AREDS trial omega-3 fatty acids, as well as some carotenoids. Smoking cessation and blue light have also been investigated as potential interventions to reduce the effect of dry macular degeneration. Finally, when dry macular degeneration is occurring and resulting in visual loss, the primary pathway through which that happens is called cell apoptosis, which is cell death. That is, as we saw those yellowish drusen develop under the retina overlying that is damaged, and those cells, the photoreceptors, die. That's what leads to the visual loss in dry macular degeneration. And so one of the research pathways looking at trying to prevent that visual loss are looking at ways to stop cell apoptosis, including complement activation and other immune factors. That is, why do these cells die because of the presence of the drusen? What is it? And how can we prevent that with treatment? There are multiple forms of macular degenerations, some of which are the classic age-related, others are genetic disorders. And fundamentally, they all share at a common endpoint loss of the photoreceptor layer. This is the layer of the retina that actually has the cells that convert light into nerve impulses. And several molecules have been looked at. One exciting one is ciliary neurotrophic factor, in which they had a dog model of retinitis pigmentosa, a disease that damages the photoreceptors. They treated with CNTF, and you can see the difference between those retinas that were treated and those that weren't. The photoreceptor is healthy and essentially normal in the treated eyes, as opposed to thin and atrophic. The exciting thing about CNTF is not just the molecule, but the way it was delivered. And it was delivered with encapsulated cell technology, which is very exciting. Our whole framework for drug treatment so far has been for the drugs to be made in a factory or somewhere and delivered. But rather than doing that, especially since a lot of the new medications are biologicals, that means to say they're not made in test tubes, but they're made by genetically modified cells, can we actually, rather than make the drug itself, implant the actual cells that make the drug? And CNTF and the ECT technology was the first time this was done. That is, they took these recombinant, these artificially made cells that are actually alive and producing drug, put them in a little pellet, and surgically implanted that pellet in the eye. That results in those cells continuing to produce the drug continuously. So that's an exciting avenue for the future. And this is an eye that has had one of those pellets inserted. Wet AMD is always preceded by dry macular degeneration. 90% of people will only have the dry form. That is, only 10% will progress from dry to wet. But the question is, why do they progress and what can we do to stop it? And that process is called angiogenesis, or growth of new blood vessels. And so that's what distinguishes dry from wet. That is, somebody goes on for years and years and years with dry macular degeneration and fairly, hopefully in many cases, mild symptoms, but then abnormal blood vessels grow, or angiogenesis starts. And those abnormal blood vessels lead to the leakage and bleeding that causes damage. So there are two avenues that are being looked at in terms of angiogenesis. One is to block the triggers that start the whole thing off, and the other is, once angiogenesis starts, how to stop it. So why do we develop abnormal blood vessels? Well, the research for this came out of the tumor literature. That is, when people develop a tumor, that tumor grows and develops a blood supply, but that doesn't make sense. Why would your body send blood vessels to a tumor that presumably you don't want. And the reason is that that tumor sends out growth factors that cause those new blood vessels to grow. Judith Folkman investigated those growth factors with an eye towards controlling tumor growth. That is, if we stop the blood vessels from growing and feeding this tumor, then the tumor can't grow. The primary growth factor is called vascular endothelial growth factor. And as you can see, it's got a complicated chain of events by which it causes new blood vessels to grow. Back in 2004, the FDA approved a drug called Avastin to block the growth of blood vessels in tumors, primarily at that point in colon cancer, but since then it's been used in other cancers. Drug developers quickly realized that that same process is occurring in the back of the eye. And so if we can stop this growth factor from allowing abnormal blood vessels to grow, maybe we can stop these abnormal blood vessels not just in tumors, but also in macular degeneration. And the first drug that did that was a drug called Macugen. Following Macugen, two other drugs were developed. Avastin, as previously mentioned, was developed for use in colon cancer, and the same company that makes that developed a drug called Lucentis. Other ways for blocking VEGF, including blocking RNAs and trapping VEGF, have been developed. So far, everything that we have available targets the same molecule, which is VEGF. But there are other growth factors, including platelet-derived growth factor and embryonic growth factor. And new drugs are in the pipeline to attack not just VEGF, but the other growth factors. This demonstrates the primary tools that we have right now for attacking VEGF. The first drug, as I mentioned, was Macugen, which basically binds to VEGF and renders it inert. A second class of drugs are antibodies or antibody fragments, such as Avastin and Lucentis, again, which bind to VEGF. There are kinase inhibitors in the pipeline now, which do not modify the actual VEGF molecule, but prevent the next step in the chain. And finally, most recently, the VEGF trap has been approved by the FDA. And what the VEGF trap does is it binds to it, and it doesn't render it inert, but rather by binding to it, it targets VEGF for removal from the body. And so the bottom line is that the VEGF doesn't do the bad stuff that we don't want it to do. This is the newest drug that's been approved, the VEGF trap. It's called Eylea. And it binds all the different forms of VEGF as well as placental growth factor because they're both very similar. So now that we have a few tools, what determines what we use? And it used to be primarily based on location because our main treatment was laser. So whether or not you could have laser and what kind of laser depended on where the lesion was. Now it's much more of a function of what type of lesion it is. That is, since most of our treatments are drugs, they are present in the whole eye. So what drug we use is not necessarily determined by exactly the location of the lesion, because the drugs once injected will attack a lesion regardless of where it is, but rather what type of lesion it is, and that helps us know what type of drug would most likely get rid of it. In addition to that, the type of lesion dictates where the fluid is going to be, and how long that lesion has been there determines how mature those vessels are. And we've learned that different growth factors are responsible for maintaining and causing the maintenance, the sustenance of vessels of different maturities. So as I mentioned, the anti-VEGF antibodies are Lucentis, which is a mouse monoclonal antibody against VEGF, as well as Avastin, which is the entire antibody. So basically the two drugs are very closely related. The Lucentis is a fragment of the larger antibody. And do they work? Well, as demonstrated in this slide, this is a visual acuity on the vertical axis over time with no treatment versus with an anti-VEGF drug. And for the first time, we're not just seeing maintenance of vision. That is, this is when the patient first shows up. We're not seeing, prior to the development of these treatments, the visual acuity over time went steadily down. So with no treatment, visual acuity steadily deteriorated. These drugs, excitingly, not only maintain the vision, but on average, most patients have an increase of about 11 letters. Again, similar. The two drugs that have been in use most prominently are Lucentis and Avastin. Again, they both are antibodies to VEGF. Essentially, Avastin was developed while Lucentis was in clinical trials because there were people who needed drug and Lucentis was not yet available. They're very similar. They're both antibodies. They're produced slightly differently. Lucentis is produced in genetically modified E. coli, whereas Avastin is produced in Chinese hamster ovary cells. Doesn't matter. They both work. The new player on the block is Eylea, which you may have heard about in the press. Eylea is it targets the exact same molecule, which is VEGF, but it does it in a different way. Rather than being an antibody to VEGF, it traps the VEGF. It binds it and thereby renders it inert. The advantage of Eylea is reported to be that fewer injections. The Eylea is injected monthly for 3 injections, and then after those first 3, in the clinical trials, it was injected every other month, and the visual results were roughly comparable to those in the Lucentis trials. So where do we go from here? Well, we have a picture here of a little lab rat talking to a patient, and the lab rat's telling the patient, "I go home today. They cured me using this new miracle drug. I'm afraid it'll be years before it's approved for use in humans." And there's a little bit of truth to that. The drug development timeline is very, very long. So that if we look at starting with about 10,000 potential compounds, they get narrowed down to about 250 that go into preclinical trials. That is, the guys in the lab will come up with 10,000 potential drugs. And combing through those, about 250 are then tried in animal trials, of which, out of those 250, only about 5 make it out of the animal trials, because the other 245 either aren't safe or don't work. Out of those 5 compounds going through clinical trials in humans, the phase 1, phase 2, and phase 3 trials, one of those 5 will be approved. And that's roughly the ratio that has held for many years now. That is, for every FDA-approved drug that actually makes it out there, the guys in the lab have started with about 10,000. So there are a lot of non-starters in that group. And the typical timeline is it takes about 6 years to get it, 6.5 years to get it into humans. Once you get it into humans, there are 3 phases of trials, and each of those trial phases is about 2 years long. So by the time, from the day that it's first used in humans to the day it gets FDA approved, is typically somewhere between 7 and 9 years. If you look at where these treatments are being developed, from 1997 to about 2007, worldwide development of drugs has gone up everywhere, but you can see in the U.S. it's gone up by 100%. And this is specifically for macular degeneration. So there is a huge push for macular degeneration drugs. And finally, the last thing I want to touch on is something that's made a lot of press over the last few days, which is that Schwartz et al. Out of Jules Stein just published the preliminary results from their first 2 humans with stem cell treatment. They both received human embryonic stem cells. One patient had a form of macular degeneration called Stargardt's. The other had classic dry age-related macular degeneration. These are the pictures from the patient with Stargardt's. This is what the patient's retina looked like beforehand. This little brown stuff here, these are the clumps of retinal pigment epithelial cells that were injected. This is 1 week after surgery. This is 6 weeks after surgery. This is 3 months after surgery, and you can see those cells right there. And what's exciting is 6 months after surgery, you can see those cells there, and it looks like they have replicated. That is, they've grown. And that's very exciting. That's really where the news is, because this represents the first time that these stem cells, that these stem cells have not only taken root and survived, but actually grown. The patient with Stargardt's went from hand motion, meaning they couldn't see how many fingers you were holding in front of their face, to 5 letters on the ETDRS chart. The ETDRS chart is not the chart that you use at the doctor's office. It's a bigger chart. It's a special chart. But that is equivalent to about 2,800, which means a letter. Most people are used to, at the eye doctor's office, seeing the big E. The big E is 2,400. So 2,800 is a letter twice the size of that E. So it's a pretty big letter, but this is for a patient who prior to that couldn't even see any fingers. The patient with macular degeneration so far went from 21 letters to 28 letters, which is a significant improvement. More critically than that is that they're not showing any signs of rejection, the procedure was tolerated well, and those retinal pigment epithelial changes are several cells that have been implanted are now several months old and are surviving. So does this represent the next frontier? Hopefully, but it's very promising at this juncture. So that's basically where we stand with AMD at this point. And